Well, good morning, everybody. It's nice to see you all. We especially have Dr. Pazzetti from San Pedro Sula, Honduras, seems to have joined us today, which we're really proud to see that. Um, and thanks everybody else for coming at this unusual time. Today we have the special opportunity of Dr. Monfred, who's lectured to us before. Um, Ashkan has a colorful history of being a refugee from Iran and going to France and making it to the United States and going to Stanford University for his residency, his medical school, and his neurotology fellowship. Quite impressive when you think about where his feet started from and where he's at now. Today, he's a associate professor of surgery and neurosurgery at George Washington University, and he is going to share with us a lecture today on tumors of the temporal bone. So please proceed, Ashkan, and we really appreciate your taking the time today.
Oh, it's absolutely my pleasure to be with you. Thank you all for signing in from all over the world, different time zones. I know this is difficult to manage, especially on a Friday. So I'm most grateful. Um, this is a talk I gave at Stanford a few years back on tumors of the temporal bone, and it meant to be interactive. It's a short talk; it's not a very long talk. So please, at any time, feel free to either put a question in the chat or just unmute yourself and ask any questions you may have. I'll be delighted to speak. The idea really is this is all for you and your education. So let me know how I can be of service, and we'll proceed. The way I have organized the talk is that we will start with oh, by the way, before I go on, a lot of the images you're going to see I've borrowed from Dr. Robert Jackler and Colin Driscoll's book called The Tumors of the Ear and the Temporal Bone. As an otologist and in particular neurotologist, it's really important to have this book, and um, it has really nice diagrams and categorization of what these tumors are. I'm not sure, but I think majority of the slides are available for free on the Stanford's website. So one of the wonderful things Rob did many years ago is he actually kept the um, um, copyright on all his images. So he actually posts them on the Stanford website. So if you just put in um, Stanford and then put in Atlas Jackler, it will come up, and you can see he has a neurotology atlas and otology atlas, and I think this temporal bone book is also on that website as well. So the way I've organized the talk is we're just going to start from lateral with the external auditory canal and move all the way into the inner ear and all the tumors that encompass. It is not meant to be a comprehensive list of every possible tumor you'll see in the area, but it should provide you with about 99% of the tumors you'll encounter. And I'm trying to uh, have you think sort of give you a blueprint of how to best think about what possible tumor you're dealing with. The reason for that is tumors of the temporal bone are extremely rare. And unfortunately, if you're not looking for them, there's a chance you will miss it. And then by the time it's discovered, the tumor is huge. So what I'm trying to get across is sort of questioning why something is happening and where it could be coming from and going from there. So let's start from the outside and work inside. As you can imagine, the most common tumors of the ear and the temporal bone are going to be skin tumors. At least in the United States, the squamous cell and basal cell carcinomas are by far the largest number of any kind of cancer around or in the ear. These are cutaneous cancers, no different than the ones you get on your arm, on your leg, on your forehead, and they're treated similarly. There's no difference between them. Melanomas, a distant third, but certainly much more common than a squamous cell carcinoma of the actual ear canal, for example. You have to remember the squamous cell carcinomas, the part of the ear that sort of the sun shines over, are very different than squamous cell carcinomas that grow within the ear. Those are completely different beasts. The squamous cell carcinomas of the external ear, of the pinna, are very treatable. They're no different than squamous cell carcinomas you would get on, for example, the forehead. But the ones that grow inside of the ear canal tend to be extremely aggressive and much harder to treat. I put a picture up here just to just get the ball rolling to see. This is a nodule a patient came to see me, and it's a very tender, painful nodule. Does anybody know what this is? And it doesn't have to be one of those three options, by the way. It could be something different. But anybody wants to put in the chat or just unmute themselves and say what this is. And the key is it's painful. No takers. So most times that I put this picture up, people diagnose this as a basal cell because it has sort of these rolling edges, the pearly, but it's actually not basal cell. Basal cell usually is not painful. This is actually not even a malignant lesion. It's called Chondrodermatitis nodularis helices. A lot of times you see this in elderly men, sometimes in older women, and it's just a chondritis of the part of the helix or the Simba cartilage that's sticking out, and it rubs against a hat or rubs against the pillow, gets inflamed, and you treat it like any inflammatory thing. You just put I'm just going to Richard, I'm just going to let people in, correct? They keep coming
I'll
up.
take care of it.
Oh, okay. All right. That you just treat it with topical steroids. Just take weight off of it. You can give them a glasscock dressing or any kind of a cup dressing. So as long as they don't lay on it, it will disappear after a little while. But again, it's not cancerous. You don't need to biopsy these. So squamous cell cancers of the ear canal, as I mentioned to you, these are very different than the squamous cell cancers you see on the surface of the skin. We don't know the true pathophysiology of them, but because of the anatomy of the ear canal and the aggressiveness of these disorders, of these tumors, they require a much bigger operation than the ones you see on the surface of skin. And you can see in sort of the coronal, axial, and sagittal views of the levels of these tumors from going from left to right. You can see them sometimes they're confined to the ear canal, then they start going to the mastoid, very commonly going anteriorly, and then they can extend around the dura and be very invasive. Sometimes I see them all the way in the internal auditory canal by the time they get diagnosed. They require big operations, unfortunately. And reasoning being is the anatomy of the ear canal, all the fissures that exist in the bony and cartilaginous and bony part of the external auditory canal, the division between the bony cartilaginous portion of the ear canal, having mastoid there, tumors can spread very quickly. And I'll go over a couple of examples in there. Interestingly, the tympanic membrane seems to be a very strong barrier against tumors. Cartilage and tympanic membrane tend to be strong barriers. So if you have a tumor that's already eroded through the external auditory canal, usually that's going to be a very aggressive tumor. They tend to grow on the surface and just continue to grow across the skin instead of penetrating through sometimes. This is a typical CT of a squamous cell carcinoma of the external auditory canal. What you can imagine, what you can see on the images, can you guys see my pointer, by the way?
Yes.
Okay. What you can see on this image is that the external auditory canal bone is completely dissolved away, and it is not remodeled. It's not a smooth remodeling such as you get with keratosis obturans. It's actually eaten and is invaded completely. This actually invades into the bone here, all the way into the middle ear. And then you can see it on a coronal cut, so a vertical cut of the left ear. It actually has penetrated through the roof of the ear and ear canal, through the tegmen, and it's already going intracranial. MRIs are absolute must for squamous cell carcinomas of the ear canal because there are very subtle patterns of extension that could be missed. Interestingly, despite the fact that they're very aggressive, they're extremely treatable if you are also very aggressive with the treatment of them. And I'll go through the treatment in a little bit more detail, but knowing the extent of the tumor is crucial. And for that, you need an MRI. As you can imagine in the CT scan, you cannot see subtleties of cartilage or muscle penetration by the tumor. So if you look at these tumors, what you have on the panel on the left side of the screen is a pre-contrast T1 of a squamous cell carcinoma that is filling the external auditory canal. You can see it extending into external auditory canal and extending there anteriorly a little bit. What I would like you to pay attention to is the natural fat strands and fat patterns that you see in the pterygopalatine fossa and infratemporal fossa. This is a very good way for you to know if this tumor has actually extended itself beyond. And you have a comparison for the other side. So if you don't know if this looks normal, just compare it to the other side. The same thing that I shared with you on skull-based skull-based osteomyelitis and during the last talk stands here as well. So you can see on this patient that some of the fat patterns around the TMJ have started to change already. Do you see this? And this is the normal side. The issue is once you give contrast to the patient, because the area already has fat, even with fat saturation, sometimes everything is going to light up. So this is a very nicely done post-contrast fat saturation, but you can see it's still hard to tell if there's any tumor here compared to the other side. Let me show you even a better example. Look at this tumor. It's filled up the mastoid. Some of this is fluid, some of this tumor, but this is the main part of the tumor right here. Look inside of the pterygopalatine fossa right here. This is what it's normally supposed to look like. You see the fat strands that go into the pterygoid muscles. You can see the opening of the eustachian tube is there. And you can see the fossa of Rosenmüller. You can see the fossa looks like it's sealing up. And you can see the fat strands here are no longer there. And then if you look on post-contrast, you see there's enhancement there. So if you only jump and look at the post-contrast one, because the strands are already lighting up because on fat is hyper intense on T1, you're going to miss this. You're going to say, oh, that's, you see there's some hyperintensity here. This must be just a natural hyperintensity of fat. In reality, this tumor comes all the way to the eustachian tube opening right here. So if your resection doesn't encompass this part of the TMJ, go medial to the medial pterygoid and take all of this out, you're going to have a recurrence. Whereas if you take it out, these patients do really well. So be very careful about knowing the anatomy. Just again, learn how to read your own films, because radiologists are not very commonly will miss this, because this is not an area they look at all the time. Is this clear on everybody? Would you like me to go over it? Anybody has any questions? So to recap, your pre-contrast T1 and its fat stranding is very important for you in terms of knowing the extent of disease into the pterygopalatine fossa and infratemporal fossa. So what do we do for these tumors? Almost nobody does sleeve resection for these. It is almost impossible to catch these tumors where they're so small that a sleeve resection would be sufficient for them. By the time the patient presents, they usually get diagnosed with chronic otitis externa, then get treated with drops, antibiotics. After a few months, somebody eventually says, this doesn't make sense, and does a biopsy. What you wanted to recognize is early on is that they have a very particular look. They look like, if you think of a granulation tissue that comes when you see a cholesteatoma, they look like granulation tissue, but they're not as beefy red. And they also don't affect the skin in the other parts of the ear canal. Now, they can get super infected. So you can have an otitis externa on top of a squamous cell carcinoma. But if you see an ear canal that's completely clear everywhere, and in one area, you have lesions that look like granulation tissue, but they're not as deep red, that's usually squamous cell carcinoma, causes a lot of necrosis. You definitely want to image that patient and then biopsy them in that order. Don't biopsy things in the ear canal or in the middle ear unless you have imaged the patient, and I'll tell you why that's the case. Majority of these patients are going to get what's called a lateral temporal bone resection, and that's defined by taking everything out lateral to the IS joint. So you start from the incudistipedial joint, and everything lateral means away from the midline. That's going to come with you. Sometimes they require a complete temporal bone resection, which you take everything down to the eustachian tube and just close the eustachian tube. Everything just in the promontory, and there's no, you take all the ossicles, drill the mastoid, all of that. Sometimes you may have to sacrifice the facial nerve and graft these patients. In these patients, if there's any extension into the mastoid, always look for perineural invasion. These tumors tend to hitch a right from facial nerve and go up very quickly towards the geniculate ganglion. So this is a temporal bone resection. As I mentioned, you close off the ear and take everything lateral to the stapes, goes out with it. People sometimes do unblocked resections with the TMJ and parotid. I found this to be very difficult to do. I usually just take the ear canal out separately, take the TMJ. As long as you know where the tumor goes, you don't have to do an unblocked resection. It's almost impossible to do it in these patients without sacrificing a whole bunch of important structures to get to that area. So this is how you start. You sort of create a circle around the lateral surface of the tumor. I usually send a very like a 1 millimeter thin ribbon of tissue from the area to the pathologist to make sure my skin margins here are negative, and you can just close that primarily at the end. You have to put something underneath this, yeah? You can't just close a thin skin of the tragus to the concha and hope that's going to take. It's just going to fall apart. So we'll go over what to put underneath it later, but you have to make sure skin is just sitting on something and not just air because it will just die. After you do that and close off, and you're going to reflect the ear anteriorly because you've gone post-auricular, you do a quick mastoidectomy, you find your facial nerve, you drill the facial recess open, and remember the facial recess is between the chorda tympani and facial nerve. Once you have done this, you can cut the chorda tympani. There's no way for you to preserve that because your canal cuts usually will go through the area anyway. Um, you can see the malleus, you can see the incus. This is a right ear, obviously. You can see the stapes, stapedial tendon, and you can see the balance canals there. Once you do that, the first thing you have to do is cut the IS joint. Now remember, this is not a stapes operation. That stapes is mobile. So if you're cutting the IS joint and you're not careful with it, you can actually cause the stapes to sublux. And then that causes deafness and vertigo, which a cancer patient, that's the last thing you need to have the patient be suffering with. So be very gentle. I usually park my suction on the stapes as I'm cutting the joint across. And you always want to cut from a posterior to anterior when you cut these joints. The reason being the arch of the stapes it has much more strength in this orientation than in this orientation. Yeah, does it make sense? The stapedial tendon is holding it on one end, and the arches are stronger in that orientation. So try to cut from posterior to anterior. I usually use a myringotomy knife. They tend to be sharper than the joint knives that we use for a stapes operation. But whatever you use, be very, very gentle. As you cut that IS joint, just go ahead and remove the incus. By removing incus, it allows you to drill this area into the epitympanum much easier. You don't need to keep the incus to, it just looks good, but you don't need to do that. It actually gives you more room to drill. Once you do that, you're going to continue your drilling all the way to the TMJ anteriorly, and then all the way inferiorly, and you're going to follow the contours of the annulus. The other thing you do is you obviously need to skeletonize the facial nerve to know where the facial nerve is, because the nerve doesn't always live here. The facial nerve is only fairly consistent at the genu. As soon as you come out of the genu, it can come all the way back here, it can go all the way forward here, it can come back here and then go back up here, it can go lateral, it can go medial. So it's always best to identify the facial nerve at near the genu, where you have the incus and you see the genu, and then follow it all the way down towards the mastoid tip. You have to have the entire length open, as I said, because you don't know what's the relationship between the nerve and the ear canal. Once you have this, you can proceed with taking the ear canal out. At this time, just transect the chorda tympani sharply. Don't drill on it near the facial nerve because it will pull on the facial nerve and it will cause a hematoma inside of the nerve. So once you have the chorda tympani identified, clean it all the way to the nerve and then just get like an 11 blade and just transect it sharply. Then you can just make your bony cuts just inferiorly here and superiorly here. This is a superior cut, and you're going to do this to all your way to get to the temporomandibular joint, to the glenoid fossa. It is very, very hard to get to the anterior canal. So if you think about the ear canal as a cylinder, so you can do the facial recess, you get the posterior, you do an inferior trough, you do a superior trough, but then you need the ear canal is still connected anteriorly. Do you guys remember what's living right underneath the wall of the ear canal anteriorly? Can anybody say what's on that? What structure is underneath it?
Carotid.
Hmm?
Carotid.
So this is from Rob Jackler's Atlas many years ago, and I gave up doing this the first time I saw this operation done because putting a chisel in the wall of the ear canal and then having the facial nerve underneath your chisel can be dangerous. And a few years back, one of my friends We were doing a complications in otology talk, and he shared one of his slides with me that he did this and exactly right. That's what you're going to get. So the carotid artery lives right underneath that bony wall. So if you go at it with a chisel and you break the ear canal, the break can actually go right through the carotid wall and you're going to get laceration. Remember, carotid artery in the temporal bone is very thin walled. It looks like an IJ, internal jugular vein. It breaks very easily. It doesn't have the same thickness as you see the carotid in the neck. So I don't do this anymore. And that's what I said a lot of times, you just have to do this. You can't do this on block. So if I can't see the area to drill across it, if you can drill across it safely, just drill across it and then break it with your thumb. If you can't do that, just remove a part of the wall of the ear canal posteriorly to get access to that area. It's so much better than trying to get an unblocked resection and causing harm to the patient. Any question on resection so far? I don't even know if anybody is awake, so nobody says anything. So I hope this is of use to you guys. But any question on resection before we go to reconstruction?
Saeed from Ethiopia.
Yes.
Yeah. No.
Oh,
Okay.
No.
So in terms of reconstruction, as I mentioned to you, you have to fill up that cavity with something. You can certainly borrow fat from the belly, from the abdomen, and put fat in there. It has very good survival rate fat in it because it has very low metabolic rate. The issue with fat is that it doesn't withstand things like infection or radiation. And many of these patients are going to need radiation because of the extent of the disease. So I use this technique I learned from Rob Jackler in terms of using a portion of the temporalis muscle. The only difference I use is that I don't take as much of the muscle because when you take all the way to the half of the muscle, this part tends to waste a little bit more and they get a very hollow look here. You've seen people like going on chemotherapy and they get a hollow wasting of the muscle. It's very noticeable. So if the person particularly has thick muscle, you can actually just take the posterior third. So you can make your cut just along the fibers right here. Make sure you don't transect them here. The blood supply of the muscle is on here, right here. And is the blood supply on the lateral side of the muscle or on the medial side of the muscle? Does anybody remember? Is it on the outside of the muscle or on the inside of the muscle? So this muscle's blood supply is on the inside. So you can make cuts on the outside. You can go and I usually don't like using Bovie for these things or any cautery. It bleeds, but I don't like to char the muscle because it just doesn't survive as well. I usually use a cold knife for this. But be careful as you're coming down here on the outside surface, lateral surface, you're safe. On the medial surface, that's where the blood supply of the muscle is. So if you keep cauterizing with the Bovie or bipolar on the medial side of the muscle, you're going to kill the flap. So just be very careful and just very gently extend it down. What you can also get is all the pericranium, the periosteum, attached to the muscle. So once I make the incision, I actually put my sort of a elevator underneath and I come all the way to the top of the head and all the way to the back of the head and elevate the scalp completely off the periosteum. And then I make an incision going tunneling underneath. I just use a sharp freer and make an incision into the pericranium all the way around. So sort of from here all the way back here and all the way down to the linea temporalis. So not only get the muscle, I get all this pericranium with it. And because the pericranium is attached to the muscle, it has very good blood supply. Now you have a robust tissue. You can fill up the entire mastoid with it. All this defect down here, you can fill it up with. And you can actually create a tent across for the ear canal skin to sit on top of it. Remember I showed you don't put the ear canal skin on air? This is what you put it under. You can actually tent up the muscle and suture it to the surrounding tissue. And then you can put your ear canal skin on top of it. It'll survive every time because it has a vascularized tissue underneath it. Even if it doesn't survive, you have muscle underneath. It will granulate, and after a few weeks, it will completely heal and there won't be an issue. Any question on reconstruction? All right, you guys can go back and email me if you have any questions. I'm going to keep going. Other tumors of the ear canal. Always important to remember what else lives near the ear canal. Remember, ear canal, 5 bones coming together, but the front wall, you have the TMJ, so you can say get tumors from the temporal mandibular joint, like PVNS tumors can come from the temporal mandibular joint. You can get things from the cerumen producing, wax producing glands inside of the canal. You can get from parotid very commonly. We see cancers of the parotid eroding into the external auditory canal. Facial nerve lives in the external auditory canal. And of course, dura is on the roof. Yeah. So you can get tumors from any of these structures around. So what you want to do is think about what tumors are nearby. The cerumen producing gland tumors, adenomas and adenocarcinomas of the cerumen producing glands are extremely rare. But you just treat them like any kind of an adenoma or adenocarcinoma. If it's adenoma, you just resect them. If it's adenocarcinoma, you need to do a wide local excision of that area. This is a patient that was referred to me for a lesion in the external auditory canal, and the referring doctor had been treating it for months, and it just would not stop coming back, and had a little bit of pus on it, so it would get drops, antibiotics, it would keep coming back. Eventually, the um, ENT doctor, my referring doctor, biopsied it, and the biopsy comes back meningioma. So this young woman had a meningioma that had extended all the way from the dura here, do you see it? Into the bone and into the soft tissue of the ear, all the way up here into the ear canal. There's the roof of the ear canal. These are a particular type of meningiomas that have, although they are WHO1 classifications usually, they can penetrate very easily, not only through the bone, but through the skin and soft tissue. They actually invade soft tissue. So although they are classified in WHO1 classification, they tend to be extremely aggressive. So this one, we had to do a major resection and radiation afterwards, and she's 5 years out and doing excellent now. How about tumors of the middle ear? These are even more rare than the tumors of the external auditory canal. The tumors that are native to the middle ear, the most common one is going to be glomus tumors. And glomus tumors, you could have either a small glomus tympanicum, you can have a large glomus tympanicum, or you can actually have a glomus jugulare that's starting from the IJ and is going all the way up into the middle ear. So unless you can see the entire tumor in the middle ear, and you know that's just a tympanicum, be careful because you may be looking at a tip of an iceberg that's coming from the below, and it's a giant tumor and has you just seeing the tip of it inside of the ear canal. So this is a classic sort of a glomus tympanicum. They start near the Jacobson's nerve. They grow off the promontory plexus from that area, and they spread out. These, when they were small, just laser them out and take them out. There's no reason to give them radiation or do any kind of a angiography. Just do a temporal bone CT, make sure they don't extend down to the jugular vein. You see the jugular vein down here, and you can just easily resect them, and the patient is done. You just do surveillance for years to make sure they never come back. They do tend to extend fairly wide. They go down the eustachian tube into the epitympanum. I have the ones that have actually eroded over the years into the mastoid and jugular frame and jugular bulb area as well. Again, meningiomas and adenomas are the two other ones you can get in the middle ear. Adenomas are very easy to diagnose because they look like a white pearl in the middle ear, but they don't have the same shine, the shiny surface as a cholesteatoma does. You know, the congenital cholesteatoma is just like a pearl. These are sort of a beige color. This is what they are. They're easy to diagnose, and you just take them out. This is a patient who was referred to me for eustachian tube dysfunction, and actually had a meningioma growing into the eustachian tube from above, causing her eustachian tube dysfunction. And it took years for it to be diagnosed. I always tell my resident and medical student colleagues that always ask why. Never become a pattern recognizing doctor. You always have to say, why does this patient have eustachian tube dysfunction? Is this a child? Fine. Is this an adult with chronic history of allergies and nasal polyps? Fine, those make sense. If you have a 30-year-old, 50-year-old, 70-year-old with one-sided eustachian tube dysfunction, it behooves you to look into it, see why that patient has that. If they have a common cold, they have fluid right after, fine. But if they just have fluid in the ear all of a sudden, you do a nasal endoscopy, make sure they don't have a nasopharyngeal carcinoma. If that's negative, image them. because you don't want to miss a tumor, causing the eustachian tube dysfunction. Always ask why things happen. We don't always have answers, but at least you will do your best due diligence. This is a CT of an 80-year-old that was referred to me for a glomus tumor, and it was hard to tell if it's a glomus jugulare or glomus tympanicum. So I will, hopefully this will play. There we go. You can see it's a left-sided tumor. You can see the external auditory canal coming in. You can see the mastoid bone. You see the mastoid is filled with fluid. This is not tumor. This is just backup of fluid in here because the tumor is filled up the middle ear. You can see the sigmoid sinus. And what you want to do is pay attention here. This is the jugular vein, yeah, and dome of the jugular ball. The way you can tell if something is a glomus tympanicum coming down versus a glomus jugulare going up, you see this bony plate here? If this bony plate is eroded, it's usually a jugulare that's eroding upwards. If the bony plate's intact, doesn't matter how big this tumor is in the middle ear and mastoid, it is still a tympanicum. The importance for that to know is that if it's not connected to the jugular vein, it's a different surgery you will do than if it's going into the jugular vein. Also, the blood supply is different. If it's a glomus jugulare tumor, usually they have very robust blood supply from ascending pharyngeal, and you should try to embolize those. If it's glomus tympanicum, they parasitize little blood vessels from carotid, from middle meningeal. You really can't do an embolization as well. So it's good to recognize which one you're dealing with. Anyway, pay attention to this area, please. You can see the bone there. And as you go up, you see the plate's completely intact. Now you start seeing tumor cells. One thing that makes it really difficult with glomus tumors is that they mimic bone marrow. They don't grow in a nice round way. They send these tiny little tentacles everywhere into the air cells. And unless you look very carefully and pre-op, post-op CT and pre-op and post-op MRI, it is very easy to miss them. Again, look for the fat signal on a pre-contrast T1. And this tumor is all the way to the carotid artery. You see this? This is all tumor. It's very easy to mistake this for just bone marrow. You can see the tumor here, goes into the middle ear, into the eustachian tube opening, around the ossicles, and then into the mastoid. Interestingly, of all these I've taken out, I've never seen them erode any ossicles. I don't know if, Richard, have you ever seen a glomus tumor erode ossicles? They live around them, but they don't eat the ossicles. So almost all these patients, you can preserve them.
Yeah.
Yeah. All right. Any question on glomus tumors before I go? Nope. All right. This is going to get a little bit more challenging. Now, these are the tumors that grow in the inner ear, and there's only one. Does anybody know what does the only tumor that ever grows in the inner ear is? Anybody wants to venture a guess? I'm sorry, let me make sure this is not from. So the only tumors that have ever been reported to grow inside of the inner ear are schwannomas. And these are all, they call them intralabyrinthine or intracochlear schwannomas. No other tumor has ever been reported in the ear. There's never been a hair cell tumor. There's never been a supporting cell tumor, nothing. The only tumor it's ever seen is schwannomas. And the theory is that they grow from the nerve endings of the cochlear nerve inside of the cochlea, or the nerve endings of the vestibular nerve inside of the vestibule. So this is what you're looking at is an axial cut of the bilateral internal auditory canals. And then you can see the cochlea on the right. You can see the vestibule, the lateral semicircular canal. Look at the cochlea's mid-turn on the left side. You see how bright it is? You can see on the coronal now, you're looking head on now, the right cochlea is same color as fluid. The left cochlea is very bright. So this could be one of two things. It's either labyrinthitis, yeah, there's an infection, or there's a tumor. How can you tell? Well, you look at your Fiesta sequences or KISS sequence, depending on if it's a Toshiba or GE machine, they call them either Fiesta or KISS. All these are very thin cut or 1 millimeter cut T2 MRI. So fluid is really bright on them. You can see the fluid in the cochlea on the right, but you see on the left side, the fluid comes here, the perilymph comes, and then there's nothing. There's no fluid anymore, and then you can catch it at the very apical turn. If you look on the 3D model reconstruction, you can see the basal turn, mid-turn, apical turn. You can see the basal turn. There's no mid-turn of cochlea. There's an apical turn. So you know there is a lesion sitting there. If this were labyrinthitis, the fluid would still be there. But because the fluid is excluded, the perilymph is excluded by this tumor, you know you're dealing with a schwannoma. These tumors, usually treat them with monitoring because they tend to grow within the cochlea and then eventually go through the modulus into the IAC. It is always best to diagnose them early, and if you see them growing in the cochlea, you can just do a cochleectomy and take them out, either transcanal or go postauricular, and then drill the cochlea open and take the tumor out. Don't allow them to get into the IAC because then you're looking at a bigger operation. This is a young lady who was referred to me for right sensorineural hearing loss. And again, you can see on the axial post-contrast T1, there's a lesion in the IAC. But when I looked carefully, she had a second lesion inside of the labyrinth. Do you see it? And they don't seem to be connected. On pre-contrast, you see, it's not intense pre-contrast. And on the Fiesta, you can see it all filling up the internal auditory canal, sort of a raggedy shape. It doesn't have that nice smooth shape of acoustics do. And then you can't see the labyrinth. You see the labyrinth on this side? You can't see it on the other side. Any guesses what this is? So this patient doesn't have NF2, correct? Because she doesn't have a tumor on the other side. But that was one idea, is that this patient has two separate tumors growing on the same vestibular nerve, like some of the NF2 patients make. But I think going back through her history and realizing how long ago she started going deaf, my theory was that this actually started as an intralabyrinthine schwannoma and actually grew into the IAC. And these tumors, they become cystic and parts of it disappear. So this part no longer picks up contrast. But this is just one tumor that started in the labyrinth and went into the IAC. And I've just been monitoring her for years. It's never grown anymore. So we're just leaving it alone. But always look into the cochlea. If you have especially a patient with sudden sensorineural hearing loss, I've had quite a few of intracochlear schwannomas that have been missed by the radiologist because they say it's just labyrinthitis and missed looking at the Fiesta sequence. All right. So other tumors that grow in the area, facial nerve schwannomas. This is sort of the most classic image of a facial nerve schwannoma you can get. It's a tumor that's dumbbell shaped. It's growing around the geniculate into the middle ear. It's growing in the cerebropontine angle. And the classic sign on the CT scan is that the labyrinthine segment of the facial nerve is really dilated. Do you see that? This area is supposed to be 0.86 millimeter in diameter in almost every person. There are very few exceptions, but in most people, that is a very narrow segment. When it is this wide on one side and normal on the other side, there's a chance you're looking at either a facial nerve schwannoma going through it, or sometimes we see this with intracranial hypertension. The fluid pressure pounding through will actually create a pathway through here. But anyway, this is a classic image of a facial nerve schwannoma. Now, facial nerve schwannomas can grow all the way along the facial nerve everywhere, from the middle ear, genu, into the mastoid. And very commonly, they present with the ear canal mass. You can see on this gentleman, when I saw him first, he had a mass coming right through his ear canal. If you biopsy this, that facial nerve will shut down completely. Again, never biopsy things you see in the ear canal unless you've had imaging done first and know this is not a facial nerve schwannoma. It's not a vascular structure. It's not a glomus tumor. If you ever biopsy a glomus tumor, that will ruin your day. So please be very careful. Always image first, then biopsy for anything in the ear canal, anything in the middle ear. So this is a facial nerve schwannoma. It's actually very hard to diagnose it. For longest time, we thought it might be a glomus tumor. But when you look at it very carefully, it is actually following the path of the facial nerve on a vertical cut on a coronal. You see how the facial nerve descending segment goes? And this tumor goes with it. And the pathology was also consistent with it. So I had to do a radical temporal bone resection for this patient. Now, these tumors are very rare, thankfully, and they're very difficult to diagnose. They used to call them geniculate ganglion um, hemangiomas. They're really not hemangiomas. Hemangiomas are tumors of capillary vessels. These are not tumors of capillary vessels. The pathology has been more consistent with vascular malformations. They grow from the tuft of vascular tissue you have on top of a geniculate ganglion. So if you look on MRIs, very commonly geniculate ganglions have a little tuft of contrast around them. It's because there are vessels that live in the geniculate ganglion. Very, very rarely these things turn into tumors. Most common presenting symptom for this patient is facial paralysis. They present with synkinesis because the nerve keeps degenerating and regenerating, degenerating and regenerating. So they'll have spasms, twitches, and sometimes they get synkinesis, which means they try to close their eye, their mouth will pull up, or vice versa. This tumor, you can see, it's really hard to diagnose. Initially, it could be thought that this is just a acoustic neuroma. Do you see it there? This is a pre-contrast, post-contrast. Do you see how it doesn't pick up contrast uniformly? That's rare for acoustics. Acoustics usually, um, if they don't pick up contrast homogeneously, you can actually see cysts inside of them where they don't pick up the contrast. And this was different. When you look at the post-contrast, you can see there's a part of the tumor coming into the middle ear, and then there's this whole part of the tumor in the middle fossa. Do you see that? Acoustics don't do that. And do you see very carefully, do you see the black line around it? That's bone. These tumors live in bone. So if you go inside looking for a soft tissue tumor, you're not going to find them. This patient actually, a neurosurgeon a few years back before me went inside, did a middle fossa craniotomy, and biopsied the geniculate ganglion, and patient had facial paralysis. Thankfully, the nerve recovered, but they say there's no tumor. The reality is, unless you drill the bone in the area and know where to drill, you're not going to find these tumors. They live inside of the bone. They're challenging tumors, but I've done a few and they have very good results usually. If you can drill it correctly and leave the nerve alone, you can get rid of the tumor, and their facial spasms usually will stop. This was another one I took out. It was really subtle. The tumor is this thing right here, this tuft that's growing around the geniculate ganglion. Remember, this part is usually solid bone. You don't have a lot of bone marrow around the geniculate ganglion, but patient came to see me because of facial spasms. On the CT, this is what we could see. This is it again on the CT. Again, really, really hard to see it. And on the MRI, this is it. There's a sort of a speckled view of contrast around the facial nerve. You see, this is a normal facial nerve, the enhancement on the left, and this is on the right side. This whole area was the tumor, and I drilled this away, and she's done really well. Last couple of tumors go over. One, sarcomas of the temporal bone. They're extremely rare. This is a Ewing sarcoma I took out of a young girl many years ago. We rarely see these things. Either rhabdomyosarcomas can grow like this in the temporal bone in children. They tend to be the most common tumors of the temporal bone. You can see eosinophilic granulomas. You can see Langerhans sort of histiocytosis tumors in this area, or just other types of sarcoma that they grow in there. Again, thankfully, they're extremely rare. They're extremely destructive. You can see all the enhancement and destruction that this tumor has done. Glomus tumors are more common. They're hard to miss because they're surrounding the jugular bulb. You can see on this axial pre-contrast T1 here. Post-contrast, you can see how well they enhance. And all these little dots that you see, these are giant blood vessels that live inside of glomus tumors. So when you see a tumor with a vessel that size, you know you're looking at a glomus tumor more likely than not. So, and they're just really centered around the dome of the jugular bulb. Endolymphatic sac tumors, usually you see them in patients with von Hippel-Lindau's disease or VHL mutations. If you catch one of these tumors, always test the patient for VHL gene defect if you can, because if they do have that mutation, they're going to have all kinds of tumors throughout their life, and you need to monitor them for that. If they're VHL negative, then usually they just have a solitary tumor of endolymphatic sac. The thing with these tumors is that they grow right off the endolymphatic sac, and they are centered around the sac, which is right next to the posterior semicircular canal. The other thing with them is that they have a very, very classic MRI pattern. Nothing else looks like them. They grow around the endolymphatic sac. Do you see that? There's a posterior semicircular canal. There's a lateral canal. The tumor is right there. They are hyper intense on both T2 and T1 before contrast. And that's the only tumor of the temporal bone that does that. And even with fat saturation, they completely enhance. So you know you're looking at that. Okay. The other thing that's high on T1 and T2 in temporal bone is a cholesterol granuloma, but you don't mistake these for that. Cholesterol granulomas are nice and round. The bone is actually dissolved away in a nice round fashion. You can see this thing is very erosive, and it's nothing round and nice benign about it. This is invading tissue as it's going. These we treat with combination of surgery plus minus radiation, and now there are new biologics coming to the market for these tumors, the monoclonal antibodies. This is a chondrosarcoma. Chondrosarcomas and chordomas have identical MRI pattern. They tend to be very iso-intense to the brain on T1, and they are very bright on T2 because of the amount of cartilage-producing cells and proteinaceous fluid cells that they have, and they enhance avidly. So again, nothing else looks like them. It's the only tumor that's low on T1, high on T2, and enhances with contrast. So you know you're looking at either a chordoma or chondrosarcoma. And the last thing that grows in that area, of course, is metastatic disease. This is a patient with breast cancer with metastatic disease to the petrous apex. Because petrous apex has bone marrow in many patients, it has a lot of vasculature, and a lot of tumors set up shop in the petrous apex. And this patient is one of them. And you can see these tumors are extremely, extremely aggressive. You can see the entire petrous apex is replaced by this tumor. You can't even see where the carotid passes here anymore. And if you look carefully on the coronal, it's actually eating into the cochlea. There are very few tumors things can actually erode into the cochlea, and metastatic disease is one of them. Okay. This is the same patient. You can see it extending on MRI, and you can see the destruction is done on the coronal, on how much it enhances. So to summarize everything we talked about, these are rare tumors. If you see a lesion or a tumor, think what's nearby. Is it coming from the jaw joint? Is it coming from parotid? Is it coming from the dura? Is it squamous cell carcinoma? Always image, then biopsy. And do both CT and MRIs. These are tumors that you have to get both images on. And most importantly, learn to read your own films, and don't always rely on radiologists for these. They are wonderful asset and colleagues, and you'll do well to work with them closely so they can educate you and you can educate them. And that collaboration is wonderful, but you always have to learn to read them yourself as well. All right, hope this was helpful. If there are any questions, I'll be glad to answer.
Ashkan, I'll make a little comment. At one point in my younger years, when I went to Ethiopia, we would see a significant amount of Glomus jugularis, literally coming out of the ear canal. And the notion was, you know what, just take a little biopsy. If they bleed, you got a glomus and you diagnosed it. Retrospectively from your lecture today, that was probably not the right thing to do, because you're right. When you've got a facial neuroma or facial nerve tumor, and you go ahead and give them a paralysis. Or what if it doesn't bleed? You still haven't made a diagnosis. So it really doesn't pay off to just biopsy it, as you said. And unfortunately, the reason why we did that was because patients didn't have access to scans, be it CT or MRI.
Yeah, I remember those days. And the problem is that if you biopsy and you happen to capture one of the feeding arterial vessels inside of the tumor, they don't stop bleeding easily. I mean, you can compress, and after an hour or two, eventually it will clot off. But it is a mess. It is, and it's. You can imagine for a patient, it can be so traumatic to have blood pouring out of the ear, and so, yeah. I'm hoping now. I haven't been to Ethiopia in 17 years now. So I don't know how things are there now, but I'm
Well,
hoping to go this December. See, hopefully things are more available in terms of CT and MRI and all those things.
Oscar, you have a question?
Yes, thank you for a lecture. We recently actually had a topic about facial nerve tumors, and I was wondering how you manage facial nerve tumors. Do you wait until at least the House-Brackman 3 to jump into operation, or would you watch and wait? And what's your opinion on this?
That's a great question. So majority of us that's sort of been the traditional training is that wait till they get to House Brackman 3 and then do the surgery. Um, and the reason is that purely emotional, because if the patient has perfect facial function and you take the tumor out and you give them a grade 6/6 paralysis for at least 6 months, it takes between 6 months and a year for the nerve to grow back. Emotionally, that's really hard on the patient. Whereas if you allow it to slowly go paralyzed and they get to a grade 3, excuse me, and then you do the resection, they went from something that was mediocre to poor. And then when it gets back to mediocre, they're like, oh, my face is back. And emotionally, they do better. I would say there's a very small group of surgeons that if the diagnosis is very small, they go try to peel them from the nerve. And they've reported some level of success and some disasters. I can tell you, I've tackled one. We thought it's a large acoustic neuroma. It was a 1.8 centimeter or 2.8 centimeter acoustic. We thought it's an acoustic. Went inside, turned out it was a facial nerve schwannoma. Identical MRI signal. You couldn't tell them apart. And I started taking the tumor out, and after a while, it starts to stimulate, and I realized, oh my God, this is a facial nerve schwannoma. So I took as much as we could without paralyzing the face, and patient still has grade 1 facial function, but that's more of a rarity. Some of these patients, if you even just biopsy the tumor, that the nerve will completely shut down. So I haven't found a very tiny one to this day. All the things I get referred to are very large tumors. So I have never attempted trying to peel one of these facial nerve schwannomas off the nerve. Because they come from the Schwann cells, they're not true neuromas. You can technically do it, but it really may not be feasible. And you go from somebody who has a perfect face to somebody who has, grade 6 in one day. Now, the other thing to bear in mind is what is the lesion doing? So I have a 17-year-old I'm operating on in the next couple of weeks with a facial nerve schwannoma that's purely in the mastoid segment. And he has a grade 3, but it's a good grade 3. I mean, if he doesn't smile or anything, you can't tell. The only time you can tell is as soon as he tries to make any movement, you see the asymmetry, and he can close his eye with a lot of force, but doesn't close easily. So he's not a grade 2, he's actually a grade 3. Um, the reason I'm operating on him and not waiting any longer is that the tumor has actually grown all the way into the middle ear. If I wait any longer, that tumor is going to grow through the middle ear, potentially into the geniculate ganglion. And now my surgery is going to become a lot more complicated. Not my surgery, his recovery, because now I have to do a middle fossa craniotomy, potentially take down the wall of his ear canal. Whereas now I'm hoping I can do it by just removing the incus and taking the chorda out. So doing a what we call an extended facial recess, and take the tumor out that way and graft it. So he's going to go from a grade 3, grade 6, but I wouldn't wait any longer on him. And I explained this to him and his parents, and they were very supportive of that. If he had grade 1, and if he were not 17, if he were like 50, 60 years old, you can certainly do serotactic radiation. The issue with serotactic radiation is that there's very little literature on it. Many of these tumors, when you give them radiation, they'll expand. And if your tumor expands, it's going to cause paralysis potentially. So there has been some success stories with using SRT, their CyberKnife, Gamma Knife, whatever you have for these facial nerve schwannomas. I have not seen a wonderful, convincing article with 20-year follow-up on these tumors, but that is one possibility. Other things people have done is doing decompression. So if you find them into the IICU, decompress the IICU and allow them to expand, that can buy the person a few years potentially. Again, this is all theoretical. There's never been a double-blinded study on this, obviously. that is my approach.
Thank you. Looks like there's so many factors that you should bear in mind before you make a final decision on those tumors.
Absolutely, absolutely. There's one more question in the chat about papillomas of the external auditory canal. I don't have a lot of experience with these. I had one patient that he had a lot of itching and he had papillomas on his fingers, had been scratching. And when I put the speculum in, it's just like a forest of papillomas. I just send dermatology. They treat them the same way they do papillomas on, warts on the skin. They can treat those as well. With the different agents they do. I usually don't treat these
Are you
patients.
talking about condyloma acuminata? Yeah, I've had some experience. Podophyllin is a topical medication that's been used. I honestly didn't have much success for it, and I started using low voltage cautery, trying to burn it down.
Yeah, so the dermatologist for this young man that I sent to them, he I can't remember, it was a he or she dermatologist, cauterized them using liquid nitrogen, and then I can't remember if she did an injection or did a topical, and they never came back. So there's a lot more agents now for warts than were around before. So
you got to ask yourself, how do people get condylomas? I mean,
it's not condyloma accunatum. It's actually a wart. I think there are different viruses. If I'm not 100% sure. Don't quote me on that. But these are very similar to the warts you get on your fingers, and people get them from scratching their ear.
Condyloma acuminata is the venereal wart, which
yeah,
completely different from what you're talking.
Okay. Yeah, no, the ones I've seen are just papillomas that like you get on the warts, and this patient had him on his fingers, and he must have just scratched his ear, got him there.
Okay, any other questions? Well, let's call it a weekend then. I appreciate Ashkan's time and,
of course,
knowledge. He's beyond a doubt. He knows his tumors better than anybody I know.
You're very kind.
Tumors are another venue. And unless there's any other questions, Ashkan, thank you. Everybody have a nice
Thank you.
weekend.
My pleasure.
Any messages or questions, please put them in chat. They'll get to Ashkan and we'll get back to you guys. So have a pleasant weekend, everybody. Stay safe. Our friends in Ethiopia, we hope you're doing okay. In the north, Neela is in India. She just got married a few weeks ago, and
congratulations.
Coronavirus is still a big problem there. And anybody else got anything to share? Please join in on the WhatsApp platform. Okay, Ashkan, thank you.
Thank you. Always a pleasure. Take care, guys.